Hello, and welcome to TraumaBytes. We have put together another edition of our program on trauma performance improvement, or PI. Keep it simple. Today's session is on the Corrective Action Plan. This series is brought to you by AMN Healthcare Revenue Cycle Solutions. I am Susan Schmunk and will be serving as your facilitator for this conversation with Christie Carroll. Together, we bring 35 years of trauma experience to the table. If you are interested in further information on either of us, I will be sharing our brief biographies at the end of this session. In previous podcasts, we have explored National Trauma Data Standard, or NTDS, complications and their impact on patient care, audit filters and the optimization of your data, and lastly, driving measurable improvement through performance improvement, or PI, tools. Our objectives for this session are to define the corrective action plan, identify when a corrective action plan is necessary, establish key features of a corrective action plan, and identify ways to incorporate report writing features into a corrective action plan. Hello, Christie. Are you ready to get started?
Hi, Sue. I am.
All right. So how would you describe what a corrective action plan is designed to do?
So, a corrective action plan is designed to describe what action an institution or facility is going to take within a specific time frame, so a set time, to address or correct any findings of an identified risk or non-compliance and to prevent recurrence. So that's a long way of saying it's what action is your facility going to take to fix a problem you've identified.
All right. And if we're going to be identifying those corrective actions, how do we go about doing that?
So things that are identified usually come through your process of PI. So it could be through audit filters, it could be through your core measures, protocol audits, it could be through running a report through your trauma database. It could be that through those you identify that problem or that issue, and then you can start breaking it down into what are we going to do about it and how long is that going to take. But those key issues come from your routine or even your referred PI activities.
Okay, so you've identified that issue you want to correct or that opportunity for improvement. What's the next step?
So once you've identified that issue, you need to develop a response to that problem. So this is the kind of gathering all the information of, okay, we know we have a problem. Now what are we going to do about it? And then how are we going to do it? And when do we want it done by? So it's kind of the putting it all together so that you can come up with a solution and a viable solution.
So it's the nuts and bolts of what you're going to do.
That's right, those nuts and bolts. So it's kind of gathering all of the who, what, when, where, and how.
Okay. And is there any way to break down those components?
There is. So if you look at kind of the components of uh, that process, you really want to know a couple of things. One, you want to identify kind of the level of harm that was identified with that issue. So once you identify that there is the issue, you want to look at, well, was there no harm caused? Was there a potential for harm? Was there minimal harm, moderate harm, severe harm, or, in worst case scenario, was there death related to this issue? And then those recommendations that come out of that are typically driven by your trauma committee. So through that process, the conversation happens through the committee. Once those key features are identified, then you've really got to determine who was involved or who should be involved in the discussion. So it could be staff involved in the issue. It could be staff involved in the issue plus your trauma medical director, your trauma program manager, your department managers, or nursing supervisors, or physician um, instructors. So it kind of depends on what was going on. So that may be the who. Then what needs to be done to correct the issue? Sometimes it's a very easy fix, but this is the discussion that allows that what to be identified. And then when or how often should these actions be carried out? If you're trying to make a change to a process, say in the operating room, you're going to want to make sure that that happens for every single patient, every single time who is going to the OR. So things like that, marking the right side and the right site, came out of processes like these. And then where should that action occur? So maybe it's not an issue with the OR, maybe it's an issue uh, with the ED and communication between the ED and the OR. And the OR needs to be able to prepare their level 1 or their pressure infusers, and that information needs to be communicated by the emergency department to the OR. So that's the where should that action occur. And then how? How can we put these actions together to prevent recurrence of the issue? And the how helps to build and identify ways to really use our strengths and address our weaknesses in a very open and honest kind of way with our team. And it's really good to have that collaborative input, because what I see as an issue may not be what somebody else sees as an issue, or what I think is the issue may be very narrow to the full issue. And having that collaborative effort really brings the whole picture into a much more clear vision.
So let's talk about some of these potential opportunities for improvement. Could you give us some examples?
Sure. So you have potentials for opportunities for improvement. So, for example, say you have a critical trauma activation that needs to go to the OR. And through your registry, you've been able to identify that, our times have gotten longer. What's going on? Get everybody to the table and okay, this is what our process is. What's changed? This is what it was 6 months ago. So say it's been over the last 6 months. Maybe there are new procedures in place in the OR that your team was not aware of. So it could be as easy as writing that corrective action plan to address education of staff. It could be that you need to develop a process or a procedure, like what could be called a red line to the OR, and it is a straight line from the trauma bay to the OR, where all obstacles have been removed. And so that shortens that time from a critical trauma that needs to go to the OR right away, to from the time they hit the door in the ED till the time they get to the OR suite, could be a matter of a few minutes versus 20, 25, 30. So these are the kinds of processes changes that we're looking at. It also could be that, okay, we've identified a delay in obtaining blood products from blood bank for various reasons. It could be that it was we didn't have the staff to go get the blood, and blood bank is far away. Uh, those kinds of things. So one solution could be, okay, well, we're going to put a blood refrigerator in the trauma bay and develop the process for staff accessing and when to use that blood. And all of these things kind of come out of that process of the identification of an issue or a near miss, or the physician saying, it's not okay that we have blood that's coming 30 minutes after a patient arrives. It needs to be here within the first few minutes. But those are the kinds of issues that really drive this whole process.
What should our goals be?
So your goals need to be really specific. And we like to break this down into those SMART goals. So your goals need to be specific, measurable, attainable, realistic, and timely. So your specific goals need to be specific to the problem. They need to be measurable. Okay, well, here's our data to support that we had a problem, And here's the data after we implemented our solution to prove that it worked. You need to have a time frame that's realistic as well, in that measurable, and that comes into the timely part of it. Attainable. This is another reason to have everybody at the table. So if you're siloed off in this discussion without all the right people at the table, you may have a goal that is completely unattainable because you don't have the systems in place to actually make that happen, or maybe you don't have the equipment in place to make that happen, there are many different things that could be in there as part of that whole process that may make your goal unattainable without having the right people at the table. And then realistic. We do like to have that pie in the sky kind of a, well, this is the fix. I know this is the fix. But you have to work with what you've got. And that's a really important part in the realistic portion is you need to know what your resources are in order to make that goal attainable and realistic. And then timely. Some goals can take months to work through. And really your corrective action plan may be a really short, okay, we fixed it in a month and here we can show you it's sustainable. Others may take time. So you could be reporting back data to your system committee for a year to assure that your solution has been sustainable. But really, it's those what we call those SMART written goals that is the aim.
Christy, we've talked a little bit about when a corrective action plan is necessary. Who directs that process?
So the actual corrective action plan process is usually directed by your trauma medical director or in conjunction with your trauma program manager. It also could entail your higher ups, your admin, and hospital committees as well. But usually that trauma medical director and the trauma program manager are the ones who drive this process.
And we've also talked about how to identify the key features of a corrective action plan. We've touched on those. Let's touch a little bit on the types of specific action plans.
All right. So yeah, once you get through those key features of the who, what, when, where, and how, um, you really want to get into the types of specific action plans because it could vary depending on the problem. So some types of specific action plans, just a few examples, are a change in policy or procedure, and ideally an evidence-based change in policy or procedure. It could be the development of an educational offering. So things like grand rounds, conferences, journal clubs. Maybe you have a teaching institution where you have residents presenting cases at their M&M conference. You have additional resource procurement as another type of action plan. This one would be important for if you're trying to get additional staffing or equipment. And really key on this one would, of course, be the financial impact of that procurement of additional resources. Another type would be internal hospital functions or your process improvement committee work group or referral to hospital PI. You could have an ongoing I apologize, I'm a little tongue-tied. Ongoing professional practice evaluation, or what we refer to as an OPPE, or you may have a focused professional practice evaluation, which is an FPPE. And usually the trauma medical director or chief administrator will be responsible for these. And these are really more specific to behavioral events. So say you have a physician who is behaving badly in front of patients, staff, visitors, or is having a really poor attitude and it's affecting how they're interacting with people. This one is really kind of hard to identify because they're not always documented well, but it is necessary to intervene. And there's limited effectiveness, of course, depending on a lot of factors, but it's also time sensitive. So with these kinds of incidents, you want to catch them up front and right after they happen. Usually it involves a face-to-face kind of conference between the TMD or chief administrator. It just needs to be documented and what was done and if there's going to be further tracking. Another type of specific action plan could have to do with external and internal committee referrals or consultations. So this might be your ACS review. It's possible that they could recommend a corrective action plan be written regarding a certain type of incidents or a certain type of issue that they identify. Uh, Another type would be tabulation and tracking for further reporting. So say, for example, you have a physician who is late to the trauma bay uh, all the time. More than 50% of the time or more than 80% of the time. They're just late. So there's some counseling that would need to happen. And it could be that, okay, here's a change of process. When you, physician, walk into the trauma bay, you're going to walk up to the nurse who documents the time of arrival and say, please document that I'm here and the time. And then from there, you can go back and track their timeliness. I can say that I've had personal experience with that being very effective. But that was one of those tabulation and tracking. And so that's a thing that we report back out on a consistent basis is that timeliness. In an ongoing professional practice evaluation, like I spoke of a little bit earlier, that requires appropriate attribution to the providers and data collection. It's really important. So if you are saying, hey, Dr. Smith was not arriving on time to his traumas, well, maybe the nurse documented incorrectly and he was not the doctor of attribution. So that pulling information from data collection can be really important because we want to attribute the right things to physicians, whether they be positive or areas for improvement. In severe cases, it could involve some privilege or credentialing review. Uh, and maybe even loss of privileges or revoking of appointed status if it's really egregious.
So what types of different results might you have? You talked about, counseling. What are some of the other results?
So some of the other results that could come out of this are you could end up with steps being taken to change policies. You could end up with steps being taken to provide education or on a focused area of study. So say you have or mentorship. So maybe you have a physician who has higher rates of infection in the OR. So have a second surgeon go in with them and see what they're doing, how they're doing things. And maybe it's just a slight change of practice that would then decrease those infection rates. So it could be that uh, they have a specific area of focus that they need to have some education on. So the trauma program medical director may say, hey, I want you to attend this course. Bring back proof that you've completed this course. It could be, you know, as simple as that. It could be that, you need to spend more time mentoring, and this often happens in teaching institutions with the fellows. You need to spend some more time mentoring on this specific area. And so they'll pair them with the physician or surgeon who really can help them to grow in that area. And then it's tracked and reported back out through PI committee and documented, of course, within that physician's record usually. But it all has to be consistent with the medical staff bylaws and policies for remediation that are already part of your hospital PI program, or at least already should be part of your hospital PI program.
So let's talk a little bit about the more systemic issues.
Okay, so you may have some systemic issues. So when you're looking at a systemic issue, you're looking at not just a provider, but you're looking at the bigger picture of how your trauma system is working. And so it's usually led by your trauma program manager and your trauma medical director. It may even involve hospital quality committee to perform a root cause analysis. And that root cause analysis is usually used for cases that cannot be resolved quickly and are repeated and systematic. So it could start as early as pre-hospital and go all the way through discharge when you're looking at systematic issues. It could be that you're looking at the system of how certain units in the hospital interact with each other. So it could be ED and lab and OR. It could be, OR to PACU to ICU. It really just depends on what's going on. So that root cause analysis kind of helps to identify where that issue really is. With your systemic issues, you usually use data from your registry and your PI and best practices whenever available. It could require peer review or process review internally or externally. So if you have an issue that you decide your trauma medical director says, I really want to send this out to another trauma medical director to take a look at. I want to see what they would do. That would be an external review. But the goal is patient safety, bottom line, patients first, and benefit by review of system impact of the planned intervention. So really, it's looking at patient safety first and the benefit that that change in the system and that impact on the change of the system of whatever intervention you come up with is going to be. So not just in impact on patient care, but you're also looking at is there going to be a financial cost to get additional staff? Is there going to be additional equipment? Is there just a change in process here that doesn't have a financial impact, or maybe it's a positive financial impact that, hey, it's going to save us money if we make these changes. Um, in addition to that, your corrective action plans, they really can be very complex and have multiple steps of implementation. And oftentimes you find yourself having to do them in order. So step 1, 2, 3, and if you jump ahead, you miss something. So it's really important to have it well conceptualized, and it really does, it just requires collaboration with other departments. And sometimes it could be really unusual partnerships. So, it might be that you come up with an unusual partnership between, say, uh, chaplain services and a vendor that you never would have thought about, but that then is able to provide resources to support your families of trauma patients who are experiencing loss. Say there's a death in the ED that was unexpected and particularly tragic, and you just don't have the resources or the people to help deal with that. So there's a lot of unusual things that can happen there, but always with the goal of patient safety and patients first in mind. Um, and of course, once you've done all of this, your conclusions need to be documented and available for review, and that usually happens through the minutes of your PI committee.
And so what I'm hearing here is that generally speaking, we are talking about opportunities for improvement that occur more than once.
Generally speaking, yes. There could be certain cases where it could have occurred once, and the team identifies that we need to never let this happen again. So, for example, you have a pediatric patient who comes in with multi-system trauma who is in need of uh, interventional radiology. And it just so happens that your interventional radiologist that day does not have the equipment available and needed. They don't have the right size catheters. And it's an unusual situation, but why did it happen? And why was there then a delay for this patient who needed interventional radiology to go to interventional radiology? So in a root cause analysis, you might be able to identify that, well, what happened was you had 3 pediatric patients who all had procedures that day. The person who usually orders the supplies was out sick, and so supplies were not identified as low when they normally would have been. So how now do we protect our patients from that happening again? And it might be that you build in a double check. It could be that, yes, the person who is responsible for ordering supplies is not there, but there's a double check put in place. So something as simple as that could be a one-time issue where it drives that change in a process. But generally speaking, most of the time, these are recurring kind of issues where, I think we could do better. It seems like we have a problem with these things, and here's the data to support it. So, how do we make this change?
Let's talk about implementation.
Sure. So, implementation can be one of your biggest challenges in the corrective action process. And that's because it involves typically numerous individuals and departments and disciplines within the hospital. Um, and really, it could be all the staff that interacts with the patient or interacts in a certain situation with patients. So it's really a collaborative effort, and there can be some real barriers to that collaborative effort. Um, and it sounds a little strange, maybe, but trust can be a big one. So, we don't like to show our dirty laundry because it makes us vulnerable. And in this process, we really are hanging it out there for everybody to see who's involved in this committee. And it's saying, wow, guys, we have a problem. So there does take a bit of trust to be able to be effective in this. And then competition. So especially if you have multiple systems involved outside of the hospital as well, so maybe your pre-hospital or maybe a transferring facility and those kinds of things, you can have competition going that makes it difficult sometimes to work together. And really, it's keeping in mind that it is that patient safety first. And every now and then you kind of have to remind everybody involved that's the goal. And then lack of authority is another barrier that can really be difficult to get past when you're in that collaborative kind of a situation. And that is with a lack of authority, you're just going to be less effective when no one has authority to affect change. So, having the right people at the table and having the right people to have those discussions about change is really important. So, you're not going to bring a floor nurse to the table to discuss something that a floor manager needs to help implement a change with. Not that the floor nurse, input wouldn't be valuable because it is, and honestly, they drive a lot of that change in patient care, but they can't actually make the change without authorization for that to happen. So really having those right people at the table is really important. And it can be very important to have floor staff and patient care staff at the table for educational purposes and buy-in really, and to see if they are identify any barriers. Um, but really that's that collaborative effort and those barriers can be overcome. Another thing to consider is ensuring that there are processes in place to address issues with non-physician providers. So this would be your nursing staff, your tech staff, your radiology staff, your basic hospital staff. Um, and it could be through their department managers. It could be that they have shift supervisors that could deal with it. It could be that we provide education to them, and that could be through the trauma department or through the registry. Even it could be through your abstractors or your registrars when it comes down to how are we going to document this thing better. There are a lot of ways that those staff could be reached as well. And then departmental leadership in each area, you got to have their buy-in and they have to have that authority to act. If you have a department that's going to be really resistant to change or to changing a process because of, say, you have 250 ED nurses you have to educate, and you don't have an educator for that department, that's a big undertaking. So, you need that collaborative effort to figure out how that's going to go, and have that departmental leadership buy-in to make sure that that's going to happen.
Christy, let's take this opportunity to talk about report writing and how that features into a corrective action plan.
Sure, Sue. So report writing and how it features into your corrective action plan, um, they really are tied very closely together. So the whole idea with report writing is one, you've used your data to show or to support that there is that problem. It's important to be able to bring data back that shows that there's been improvement. So when you're writing your reports, you need to make sure that you have the appropriate data in there. And really not a whole bunch of extraneous things. You need to know, your number of occurrences. That N is really important. But bringing your data back to committee after you've made that change is really data dependent. So in all of gathering that data, that accurate data collection is so key. You want to report accurate data and put, garbage in equals garbage out. So what goes into the database is really important because you're only going to get out of it as good as goes in. Um, the reports that you write probably need some additional fields or filters eh, to describe what it is. So you got to make sure you've got those labels. You may also need to, in your registry, add some additional filters or fields to be able to capture the data if you're going to use your registry for that purpose. If you're not using your registry, then you might need to have a separate Excel or a spreadsheet data to support that change. So um, I would say if it's not going to be captured within the registry, that may be one of the best ways of doing it so that it can be tracked and trended and then reported out in a visual kind of format. When you do report out the data, it's got to be easy to read. So, really pay attention to the types of graphs you're looking at. And if you're just looking at an overall percentage of, hey, we're this much percent better, you're probably okay with pie graphs comparatively. But if you're looking at data over time, you're really going to want that linear graph to be able to say, hey, look, we started out really low. We've increased our compliance. Here is where we are staying in order to really demonstrate that information to your audience, which is likely going to be your hospital PI program, your hospital administration's PI program, and of course, American College of Surgeons when they come to see what you've been doing over the last 3 years. Um, and that really helps to show, that data helps to show loop closure. So it helps to show that your action plan was successful and that can all be packaged up very nicely by putting it together with this was the problem identified, this was our cause of the problem, here is our solution, this is how we implemented it, and look, here are our results. That report writing really ties into support of the problem and then support of the resolution of that problem.
Let's talk about when loop closure fails. You've identified an opportunity for improvement. You've developed this corrective action plan. You've put it through its paces, and you come back and you're just not seeing the results you want. How do you move forward?
That's a really good question, Sue. So sometimes, despite our best efforts and planning, we don't see that loop closure. And so it's essentially kind of going back to the drawing board and looking at one, look at a couple of things. One, how frequently is this occurring? Really drill down into that frequency. Two, the severity of the problem. And it may be that as you look at things again, you may find that, we felt like this was a problem. We attempted to fix it. And what we found out in the end was after reviewing all of our data, this really isn't a problem. However, we've provided education, we've done these things, so our staff really is more aware. And as much as you want to see that loop closure, sometimes your loop closure does end up being that way. However, most of the time, it doesn't. But it does take going back to the drawing board and saying, okay, guys, we tried this. This isn't working. What are some other interventions that we can do to try to address this problem and prevent it from happening again? Sometimes it could be that you forgot to get somebody at the table. Sometimes you think maybe, okay, it's a departmental issue, but then it turns out really it is a systematic issue. So really, if your corrective action plan isn't working, you need to go back and reevaluate. You need to look at your data again. You need to look at, okay, do I need to ask for a root cause analysis? Uh, do we need to change our interventions? Or maybe we haven't given it enough time. Maybe we just thought we could fix this within, a quarter, and it's actually going to take closer to 6 months to a year to fix it. So just because you've written an corrective action plan does not mean it's set in stone. It is kind of a living and breathing plan. Um, and you can make adjustments as you go, but you do definitely want that data to support your actions and if you're making changes to your corrective action plan.
Let's take a minute to talk about benchmark reports and how we can tie those into our corrective action plans.
Excellent. Yes, American College of Surgeons is, of course, very interested in our benchmark reports, and really they're valuable tools. So your benchmark reports really show you where your high levels of complications are, if you have higher mortality or complication rates than your other like facilities. And it's a really good way of identifying what you do well. And it's also a really good way of identifying what you could do better. And so if you're looking at your data and it shows you that you have a very high rate of, say, DVTs, and you are an outlier compared to your like trauma centers, okay, well, what's going on? So an example that I can give you in one of the facilities I worked at is we had these incredibly high rates of DVTs. And we looked at the data and said, this is weird. What is going on? So we drilled down into it. We found out a couple of things. We found out two things were to blame. One was our data capture of those DVTs. It was not compliant with TQIP uh, definitions. And then the other thing that we found was we had instituted a practice of ultrasounding everyone as a trauma by hospital day 3 to see if they had any DVTs. And what we were finding was we had positive rates for DVTs, but they weren't due to the trauma. They had actually come in with these DVTs and we found them, but we were taking credit for them as a complication. So it made us look like we had these really, really high DVT rates after trauma, but it really wasn't. So we made some changes as to how we were looking at those DVTs, and really we're able to support that with research and able to support that change given best practices through conversations with other facilities and published works. So that's just one little area of using those benchmark reports to really drive that process. Another area that I know many hospitals struggle with is your geriatric population. You've already got patients with a lot of comorbidities, and then you've got bad head injuries and anticoagulants on board. And so really using those benchmarking reports to say, okay, are we in line? And are we following those best practices that are published by American College of Surgeons? It really brings it back down into focus. And when you do find that you're an outlier, drilling down is so important to try to figure out, okay, where is that data? And if it is an actual problem, then it could require a corrective action plan.
Christy, have you personally done any work in collaboratives, hospital-wide or statewide collaboratives?
I have done some work in both hospital collaboratives and county collaboratives. Not so much statewide on my end, but that is definitely something that different states, depending on how their trauma systems are structured, that is something that corrective action plans can be applied to. So, if, for example, you have a state with certain triage criteria uh, for your trauma patients. And many states follow the TQIP or ACS triage criteria, but some deviate here and there. But maybe you have a state that is consistently over triaging geriatric fall patients, and you have very complicated patients whose heart rates are maybe controlled by medications. Their blood pressures may be controlled by medications. And they may or may not be showing signs of shock. And so sometimes these are the folks that get really tricky. Um, and maybe your state only has a 2-tier trauma activation type system. one thing that can be looked at is perhaps they consider a third tier for those geriatric patients who fall into a special category. It takes a lot of people at the table, though. It takes your EMS and your trauma medical directors and your state trauma medical directors, county representatives for your EMS and trauma. Everybody at the table really discussing what needs to be done here and what is our best course of action to not under triage these folks and to not over triage them either, but really to assure that they're not under triaged. So it can be a lot of agencies. I mean, here in the state I'm in, we've got hundreds of agencies that would need to be having some kind of representation at the table. Anything from ground ambulance and fire crews to helicopter crews and flight crews, medical flight crews on the EMS side of things, along with volunteer fire paramedic agencies, all the way through, your counties and regions and sometimes as down to the cities, depending on how your county is structured, and all the way through up to the state level. So it can really be quite the large gathering of people in order to affect change. And thankfully, in our current times and situation, we have technology that can really help with that and really drive and help drive that process.
Christie, I want to thank you for being with us today and helping us to understand the Corrective Action Plan. I'd like to close today's session with the thought that the overarching goal is eliminating complications to improve the care of each and every patient. Please go to the website to complete the survey and obtain your CEUs. We would also appreciate your questions for future podcasts. You may email us at TraumaBytes. The email address appears at the bottom of your screen. As mentioned before, I will continue with the biographies on our participants. So beginning with Christie. Christie Carroll is a BSN RN TC RN and is currently working as a trauma registrar and process improvement specialist with AMN. She was formerly a trauma program coordinator for an ACS verified level 1 adult and level 2 pediatric combined trauma center in Southern California. She also has worked as a trauma registrar, trauma process improvement nurse, as well as injury prevention coordinator. She has over 20 years of experience in nursing, with 19 of those being in trauma. She has spoken at many community events and trauma conferences throughout Orange County, California, and has presented research at the Eastern Association for the Surgery of Trauma. Susan Schmunk, CAISS-CSTR, is both a trauma subject matter expert and a client consultant registrar for AMN RCS in Tampa, Florida. Her background is varied, but has been focused on trauma for the last 15 years. Starting out as a trauma registrar at her local level 1 ACS and adult and level 2 ACS pediatric hospital, she was nominated for and selected as the Sherry Zalgrass Scholarship winner for the American Trauma Society in 2010. Later that year, she went on to complete the distance learning course for trauma registrars offered by the ATS. The quest for knowledge led her to become a certified specialist in trauma registry, or a CSTR, in 2014, with recertification in 2018, followed by attaining the title of CAISS, or Certified Abbreviated Injury Scoring Specialist, in 2015, and recertifying in 2021. More recently, she has focused on the area of autopsy reports and their significance to the trauma registry. This led to a presentation at the 2018 National Association of Medical Examiners, or NAME, meeting as part of a physician-led panel of medical examiners on the vital role of medical examiners and autopsy data in trauma system development. An outgrowth of this presentation was co-authoring an invited presentation at the 2018 TQIP, or Trauma Quality Improvement Program, annual meeting entitled Using Autopsy Data to Improve Care. She is currently involved at the national level with NAME and chair of the ad hoc committee on trauma. We'd like to thank you for tuning in and listening today. Again, if you have any questions, please email us at TraumaBytes, and that email address is located on the bottom of your screen. And please complete the survey for CEUs. Thank you.